Welcome to Chapter 8, Adult Language Disorders and Cognitive-Based Dysfunction. Focus questions for this chapter will include: what is aphasia? How is aphasia classified? What are the defining characteristics of aphasia syndromes? How is aphasia identified and treated? What are right hemisphere dysfunction, traumatic brain injury, and dementia? First off, let's talk about what is aphasia. We'll start off with the definition. It's a language disorder that is acquired sometime after an individual has developed language competence. So an individual is going to already have language and then they will lose it. The literal definition of aphasia is absence of language or without language. The A in the front of the word meaning absence or without. A comprehensive definition is a disturbance in the language system after language has been established or learned. It results from neurological injury to the language dominant hemisphere of the brain. Typically, that's the left side. And it includes disturbances of receptive or expressive abilities for spoken and written language. Considerations for aphasia are that it is not a developmental disorder, it's not a psychiatric problem, and it is not a motor speech disorder. Additional terminology: dysarthria, which is a weakening of the muscles used for speech, and apraxia, which deals with motor planning and the output of speech. There are different types of strokes. There are ischemic strokes, where the blood supply to the brain is inhibited because of an occlusion somewhere in the artery. And of those ischemic strokes, there are two types: a stationary type, a thrombosis ischemic stroke, where plaque builds up and closes off the artery. And then there's a traveling embolism, where accumulated plaque breaks off and travels to smaller arteries, blocking the flow of blood. Hemorrhagic strokes, where blood vessel or artery ruptures and excessive amounts of blood enter the brain. Risk factors are the uncontrollable risk factors include age, where typically older men and women are going to be affected. Gender, more men than women are affected. Racial or ethnic background. African Americans are twice as likely to suffer a stroke as are Anglo Americans. And family history. The risk factors that are controllable include hypertension, meaning high blood pressure, diabetes, tobacco smoking, and alcohol use. For example, lifestyle changes such as improving eating habits and exercising, as well as pharmaceutical interventions, can often improve symptoms of hypertension. And diabetes, although incurable, can be managed so that blood sugar levels remain within more normal ranges. And of course, reducing tobacco and alcohol use can decrease the risk of stroke. How is aphasia classified? The classification system for the aphasias is known as taxonomy. It draws on those characteristics of aphasia that most differentiate disorders from one another in an approach similar to the way we might classify automobiles. The behavioral symptoms. Some people with aphasia are unable to initiate speech at all, whereas others can initiate speech well, but produce extended, flowery monologues. Language deficits seen in aphasia are differentiated by their impact on several different areas. Those are fluency, motor output, comprehension, repetition, naming, reading, and writing. We're going to look at those each a little bit closer. In the area of fluency, a qualitative aspect of communication and speech that's used to describe its forward flow, including its phrasing, intonation, and rate. Non-fluent aphasia is characterized by short, choppy phrases or slow, labored production of speech, the presence of grammatical errors, and a telegraphic quality. Telegraphic quality means that the speech would consist mainly of verbs and nouns, leaving out smaller words. Somebody might say, want go store, instead of I want to go to the store. And it would be affecting the frontal lobe or having frontal lobe damage. Motor output for some motor systems involved with speech are compromised, resulting in a motor speech disorder. And two of those are dysarthria, which is the weakening of the muscles used in speech, as I said before, and apraxia, where the motor planning for speech is compromised. People may show slow and labored articulation of sounds with some groping of the articulators in apraxia also. In language comprehension, also known as auditory comprehension, it's the ability to understand spoken language. And aphasia characterized by comprehension problems is often referred to as receptive aphasia. And it's characterized by left temporal lobe damage. Repetition is also affected, and it is the ability to accurately reproduce verbal stimuli on demand. Some of the tasks that might be asked of someone would be to say E, or say sofa, or say no ifs, ands, or buts. And that would be compromised. The ability to repeat verbal stimuli is a major factor in differentiating among the aphasias. A little bit later, we'll talk about different types of aphasias, and in some of those, repetition is affected, in some of those, it's not. It's considered a relative strength. It is an ability that may be seriously compromised. The next category is naming or word retrieval. The ability to retrieve and produce a targeted word during conversation or more structured tasks. The word anomia, which literally means no name, is a term used to describe word finding problems or the inability to retrieve a word. Anomia patterns or types of word production errors seen in a person with aphasia might give insight into the type of aphasia, and these patterns are called paraphasias. In reading and writing, they involve the comprehension and expression of written language. Often reading and writing deficits parallel the verbal language deficits. Now looking at the different type of aphasia syndromes. There are several. Language difficulties that cluster together with different aphasias, and that's why it's called a syndrome. The syndrome part of that used to talk about the aphasia with certain language difficulties clustering. 7 major aphasia syndromes include Broca's aphasia, transcortical motor aphasia, global aphasia, Wernicke's aphasia, transcortical sensory aphasia, conduction aphasia, and anomic aphasia. First one we'll look at is Broca's aphasia. This is going to result from damage to Broca's area in the frontal lobe. It's a non-fluent expressive motor aphasia. Typically produces slow, halting, and labored speech, yielding what some describe as a telegraphic or robotic-like quality. So it's affecting the intricate motor movements for speech. People may exhibit mild to moderate auditory comprehension problems, particularly when messages increase in length and complexity or when contextual cues are removed. Transcortical motor aphasia results from damage to the frontal lobe, typically the superior and anterior portions. The symptoms are similar to Broca's aphasia as far as being non-fluent, expressive, and motor in nature, except that repetition skills are far better than spontaneous speech. Most clients with this syndrome also demonstrate strong performance in oral reading. In global aphasia, this occurs as a result of a large region of brain damage or multiple sites of brain injury in the language dominant hemispheres. There are deficits across all language modalities. They'll have non-fluent and poor language comprehension, and they will present with severe communication problems. Wernicke's aphasia is next, and this results from brain injury to the superior and posterior regions of the temporal lobe, or otherwise known as Wernicke's area, possibly reaching to the parietal lobe of the language dominant hemisphere. Fluent, receptive, and sensory aphasia. Person produces spontaneous speech that flows well with normal prosody. Prosody is the melody, intonation, and rhythm of speech. Logorrhea is talking excessively. Neologisms are new made-up words. And jargon are real words combined in meaningless form. Transcortical sensory aphasia is characterized by injuries to the language dominant hemisphere at the border of the temporal and occipital lobes or the superior region of the parietal lobe. People will demonstrate classic symptoms of Wernicke's profile, except that they will have stellar repetition skills. And if you remember from a few slides ago, we talked about some of these aphasias having repetition skills as a relative strength, and some of them where repetition skills are a definite deficiency. Echolalia is the repetition of auditory stimuli. Another is conduction aphasia, where injury to the temporal parietal region, typically a connecting pathway called the arcuate fasciculus, which connects speech production areas to speech reception areas of the brain. Fluency will be good. They will exhibit good prosody and language comprehension. The hallmarks of this type of aphasia include difficulties with repetition and reading aloud. And awareness, people are aware of difficulties with conduction aphasia. They're often frustrated. And it's often very frustrating for loved ones to watch. It's difficult for loved ones to watch anyone with any type of aphasia, but especially conduction aphasia, because the person is so aware of their difficulties and the frustration is often more profound. Anomic aphasia is not identified with any specific area of the brain or site of lesion. The person will be fluent and expressive with relatively few deficits in language expression and comprehension, with the exception of naming. The most pervasive type of chronic condition, even after treatment, and this is the most common of the aphasia profiles. So now that we've looked over some of the characteristics of each type of aphasia, how is aphasia identified and how do we treat it? Of course, we start with an assessment process. And in this assessment process, there will be the presence of a multidisciplinary team. And this might include physicians, nurses, physical therapists, occupational therapists, recreational therapists, social workers, respiratory therapists, registered dietitians, neuropsychologists, and last but not least, speech language pathologists. We'll be looking at how much spontaneous recovery is expected, which of course is probably the $64,000 question for most of the family members. The speech language pathologist's role is going to be to seek answers to the following questions. Is aphasia actually present? What type and where is the site of injury? What treatment plan should be used? What is the prognosis? And are there any other referrals that need to be made? Prognostic indicators are variables that assist in predicting recovery, which, like I said, is always on the minds of the loved ones and care providers of those who are affected. These variables are going to include the site of the brain injury, the type and size of the injury, the type and severity of the aphasia, handedness of the person, the age of the person, the pre-injury health, and the person's motivation for treatment. Often prognostic indicators are used to specify the type of treatment. The treatment of aphasia and evidence-based practice. So the goal of aphasia treatment is to correct or compensate for speech language deficits so that individuals can communicate functionally in their daily routines. And these goals are going to need to be evidence-based. In working with culturally and linguistically diverse clients, for individuals who speak multiple languages, optimal testing procedures will evaluate them in all spoken languages. Back up a second there. This might require the use of an interpreter if the person has any speech at all and is trying to be expressive, because the person might express in their first language, or if English is a second language, they may switch back and forth. Although there is still much to learn in this area of aphasia research, studies of bilingual persons with aphasia show several possible impacts. And some of those include parallel impairments, where both languages are demonstrating similar strengths and weaknesses, differential impairment, with one language showing greater impairment than another, differential aphasia, with the aphasia symptoms or profiles varying between the languages, which, as you can imagine, is pretty difficult to treat and to deal with when they're switching back and forth. Blended impairment, with the individual appearing to mix features of the languages, and selective aphasia, with only one language revealing deficits and the other being preserved. Moving on next to determining the treatment setting. Aphasia therapy is not limited to the speech language pathologist and client working in a clinic or office setting. In fact, it might be more beneficial for the client to actually be in a place where they feel comfortable or that was familiar to them prior to the aphasia setting in. They should encompass, therapies should encompass other environments to facilitate carryover and generalization of progress to different settings. As you can imagine, it would be more difficult to work on activities of daily living if you were not in the person's home where they could actually work on dressing themselves. A group approach is another consideration for treating aphasia. Measuring outcomes. Effective language treatment for persons with aphasia should be measured based on their ability to communicate in real-world situations. So, real-world communication is communication used in functional and authentic communication acts. In order to get paid for your services, a lot of times third-party payers for these types of services are going to emphasize the need for treatment to address real-world needs. For instance, Medicare, which is one of the largest payers, their guidelines focus on communicative interventions that enable individuals to communicate basic physical needs and emotional states and carry out communicative interactions in the community. So, as speech language pathologists, we need to consider how to measure these treatment outcomes to document these types of improvements. And the clinical office setting may not be the best for that. Functional outcomes or functional communication improvements are considered an essential part of the speech language pathologist's practice. What are right hemisphere dysfunction, traumatic brain injury, and dementia? And we're going to look at each of these individually and in a little bit more detail in the next slides. Right hemisphere dysfunction results from neurological damage to the right cerebral hemisphere. Aphasia can result with left hemisphere damage, even though the neurological damage is in the right hemisphere. When damage affects the right hemisphere, language and cognition may be impacted, but the symptoms are quite different from those seen with aphasia. A person may present with cognitive linguistic disorder. And characteristics are a lack of awareness of cognitive linguistic deficits and possible denial of problem areas, a lack of awareness of the left side of the body and external stimuli to the left side, difficulty recognizing faces, even of people that they are in their family. Compromised pragmatics, such as the ability to read other people's cues or recognize others' communication interests, and use physical space and affect appropriately during communication. A tendency toward using wordy expression, providing tangential information. A difficulty understanding or using higher level cognitive and linguistic skills, such as problem solving or abstract thought. And dysarthria or dysphagia, where neuromuscular systems are compromised. And let's look a little bit at the identification of right hemisphere damage. Like left hemisphere injury, right hemisphere damage requires a comprehensive speech language assessment as part of an interdisciplinary team assessment. There are some specialized batteries available for the RHD population, such as the mini inventory of right brain injury, and that's pretty widely used. Treatment of RHD and evidence-based practice. Knowledge of treatments is more limited than that for left hemisphere damage and aphasia. Initial therapy targets the management of attention and visual disruptions, since these impact productive treatment activities. So you can imagine if you're trying to have a treatment session and the person cannot attend and is interrupted by everything that they see. Therapy also targets higher level cognitive and linguistic tasks, such as thinking through functional problems. And looking at traumatic brain injury, neurological damage to the brain resulting from the impact of external forces. And some of this information on traumatic brain injury you'll recognize from the previous chapter when we went over this in children. So TBI is a leading cause of death and disability in the United States. And given the frequent long-term medical, vocational, and social needs of affected individuals, TBI represents a substantial healthcare issue in the United States. Characteristics of TBI for open head. TBI is when that occurs when the skull and the meninges have been penetrated. And then the closed head injuries, where the brain is jostled within the skull, yielding diffuse brain injury. We talked about that in reference to concussions. Polytrauma, mixture of open and closed head injury, multiple medical concerns, and post-traumatic stress disorder can result from polytrauma TBIs. The SLP works as a member of an interdisciplinary rehabilitation team to plan for treatment following a TBI. As you've probably figured out by now, with most of these more intense types of language issues, the SLP is not going to be working alone from the assessment process all the way through to treatment. There will be others from other disciplines, other professionals from other disciplines who will be helping, and you may even use a multidisciplinary approach in your therapy, which we'll talk about in a little bit. In the last chapter, we talked about the Glasgow Coma Scale, about it rating the best observed response for eye-opening and verbal response, motor response, to characterize an individual's functioning from severe to mild TBI. Treatment interventions are going to vary according to an individual's level of impairment as reflected by the Rancho scales. And those are going to look at levels 1 to 3 of being severe. And see, activities focus on arousing the individual's responses, such as alertness to the environment, attending to incoming stimuli, particularly visual and auditory. For example, the therapist might use an irritating noise like an alarm clock or a bell to attract attention. At this stage, responses will be inconsistent, even for basic commands such as blink your eyes or make a fist. Those things will be difficult. Levels 4 to 6 correspond to the middle phase of recovery. And at this stage of moderate impairment, tasks are going to focus on establishing basic communication systems, whether verbal, gestural, or augmentative, and enhancing the reliability of communication efforts. So initial communication systems may use a picture board to which the client can point to indicate things like bathroom or water or food. And clients are going to need much structure and assistance from the therapist in this phase, as they're still highly distractible and are frequently agitated or even aggressive. Schedule cards and notebooks might be good supports for orientation and memory and can help to improve goal-directed behavior. And then patients at levels 7 through 10 are in the later phases of recovery and exhibit mild impairment. The focus at this stage is facilitating independence, and treatment is going to stress insight or judgment to solve problems that are encountered in daily activities. So a client might be helped to respond to a scenario such as needing to catch the bus and being at work by 9 o'clock. You might have them look at a bus schedule and tell you which bus that they need to catch to be there on time. The next thing we'll look at is dementia. It's a chronic and progressive decline in memory, cognition, language, and personality resulting from central nervous system dysfunction. And there is diagnostic criteria from the American Psychiatric Association identifying 3 defining traits of dementia, and those include memory impairment, impairment in cognition skills, and the presence of aphasia, apraxia, and agnosia. Those are referencing an inability to recognize objects, words, or sounds. Different levels of dementia. The first one is mild dementia, where forgetfulness of basic information or common routines is present. People may lose or misplace items, and they might miss appointments. Language issues include decreased vocabulary, reduced or increased conversation skills, and anomia. Language comprehension, pragmatics, and motor skills are preserved. And then the next level of severity is moderate dementia. There will be dramatic functional change in the person, increasingly disoriented, poor attention, and memory problems. Language difficulties will include anomia, difficulty repeating, pragmatic difficulties, including understanding of humor. Motor skills will still be adequate, but restlessness and roaming are likely. And these are the stories that you might hear of people who, have gone to the same store for years and they get lost walking out of their car, forget that they were going to the store, and they find them, down the street, not even remembering that they were going to the store. Then severe dementia is characterized by extreme disorientation and minimal cognitive ability. Language is profoundly compromised. Motor skills deteriorate. So in identification of dementia, of course, we'll have a team of professionals again, evaluating suspected dementia to verify its presence, cause, and course of intervention. Medical testing will rule out other treatable illnesses that may appear like dementia or present like dementia. Some of those might include vitamin deficiency or drug toxicity. More comprehensive testing by the speech language pathologist typically involves the complete Arizona Battery for Communication Disorders of Dementia. That's kind of the golden standard for identifying the presence of dementia. Then after dementia is identified and diagnosed, treatment of dementia can start. Research continues to develop more effective pharmacological treatments to combat degenerative changes associated with dementia. Um, you may have seen ads on television talking about it will help to slow down the progressive nature of dementia. But most of these medications approved by the Food and Drug Administration are to target those with mild to moderate stages. Client and caregiver perspectives. This is definitely something that you're going to want to look at as professionals, and that professionals should recognize, because this is the impact of language disorders on the client and his family, his or her family, is going to be something that will need to be addressed. Different caregivers will have different ideas about how they want to go about handling the treatment choices for their loved one. Um, for instance, someone who's 32 years old who sustained a TBI in a car accident would probably want to go about treatment options a little bit differently from someone who's an 86-year-old woman who has progressive dementia. So, the main thing to consider and remember with this um, is that while parents are accustomed to caring for a child, the emotional toll on a family can be significant when an adult is unable to care for him or herself, but also maybe unable to even express his or her wants or needs. So this burden can be tremendous for both the individual with the language impairment and for the family. In remembering this, treatment goals should be carefully and systematically considered, and the needs of the patient and the family should also be considered in planning for treatment. That's the end of the lecture for Chapter 8. Thanks for listening.